Hello everyone. Today we will discuss about the inherited disorders of sulfur containing amino acids. Sulfur containing amino acids are methionine, cystine and cystine. Coming to the inherited disorders of these amino acids, first disorder is cystinuria. Cystinuria. This is an inherited disorder of cystine metabolism. Cystine metabolism. Here, excretion of cystine in urine increases 20 to 30 times of normal. Also, there occurs increased excretion of dibasic amino acids such as lysine, arginine and ornithine. Lysine, arginine and ornithine. So, there will be increased excretion of cystine, then dibasic amino acids such as lysine, arginine and ornithine. Cystinuria is due to renal transport defect. Renal transport defect. Here, reabsorption of these amino acids like cystine, lysine, arginine and ornithine do not occur and a single reabsorptive site is involved. This cystine is a relatively insoluble amino acid. This cystine can be precipitated in renal tubules, ureters and in bladder, and this can form cystine calculi. Cystine calculi. This cystine calculi is the major complication of this disease. In urine, a mixed disulfide of cystine and homocysteine. Mixed disulfide of cystine and homocysteine is seen in urine. This disulfide of the cystine and homocysteine, this is more soluble and thus reduces the formation of these cystine crystals or cystine calculi. Coming to the diagnosis of cystinuria, on urine examination, detection of hexagonal flat crystals in urinary deposit. Another test is, diagnostic test is the cyanide nitroprusside test. Cyanide nitroprusside. This is another test for the diagnosis of cystinuria. Here, urine sample is made alkaline with ammonium hydroxide. Made alkaline with ammonium hydroxide and then sodium cyanide is added and mixed. Sodium cyanide is added and this is then mixed. This sodium cyanide reduces cystine to cystine. It can reduce cystine to cystine. Then the cystine forms magenta red color when the sodium nitroprusside is added. When sodium nitroprusside is added, the cystine can form magenta red color. So, intensity of this magenta red color is proportional to free SH content. So, that is cyanide nitroprusside test. So, that is about cystinuria. Second inherited disorder is cystinosis. Cystinosis. This is also a hereditary abnormality of cystine metabolism. This is also abnormality of cystine metabolism. It is also known as cystine storage disease. Cystine storage disease. It is a rare familial disease characterized by deposition of cystine, sometimes as crystals in various tissues. In patients with this cystinosis, there will be accumulation of cystine in liver, spleen, bone marrow, lymph nodes, then kidneys and in cornea. This cystinosis is due to the impaired conversion of cystine to cystine. This is due to the absence of the enzyme cystine reductase. Cystine reductase. So, cystine cannot be converted to cystine. This condition may appear in children and in adults. So, 3 types of cystinosis are there. First one, in children, it is nephropathic. It is nephropathic. Here, it is acute and it can lead to renal insufficiency. Then there may be aminoaciduria, then glycosuria, then comes polyuria, then chronic acidosis, and it can lead to uremia and death. That is the first type. Then the second type is juvenile type. Juvenile type. Here renal features are similar to that of first type. Then third type is adult type. It is a benign condition. Here cystine is deposited in cornea, not in kidney. So, cystine deposited only in cornea. This cystine crystals can be detected easily in cornea by slit lamp microscopy. Slit lamp microscopy. These cystine crystals can be demonstrated in unstained preparation of peripheral blood or in biopsies of rectal mucosa. Biopsies of rectal mucosa. Then it is confirmed by chemical determination of this cystine content of peripheral leukocytes or cultured fibroblasts. So that is about cystinosis. Third inherited disorder is homocystinuria. Homocystinuria. This is of 4 types. Type 1, type 2, type 3 and type 4. In this type 1, homocystinuria, type 1 is the classical type. This is an inborn error of metabolism which involves the catabolism of methionine. Catabolism of methionine, or more specifically its metabolic intermediates, homocysteine and homocystine. Homocysteine and homocystine. So it involves the catabolism of methionine. So here there will be genetic deficiency of the enzyme cystathionin synthase. Cystathionin synthase. Usually this enzyme catalyzes the synthesis of cystathionin from homocysteine and serine to cystathionin. So homocysteine condenses the serine to form cystathionin. So here in homocystinuria type 1, there will be genetic deficiency of the enzyme cystathionin synthase. As a result, there will be accumulation of homocysteine. Then plasma level of homocysteine is increased and excreted in urine. That is overflow aminoaciduria. In some cases, S-adenosyl methionine may be excreted. Here the clinical features include mental retardation, then hepatomegaly, skeletal deformities, then dislocation of islands, then arterial or venous thrombosis, then abnormal EEG. So here sodium cyanide nitroprusside test is positive. Nitroprusside test is positive and it helps in diagnosis. So diagnosis is by sodium cyanide nitroprusside. So in addition to this classical type, there will be another types, that is type 2, type 3 and type 4. Homocystinuria type 2, type 3 and type 4. So, in the metabolism of this methionine, it can form homocysteine. It can form homocysteine. Homocysteine can be converted to methionine. This homocysteine then condenses with the serine and it can form cystathionine. Here the enzyme is cystathionine synthase, and due to the genetic deficiency of cystathionine synthase, it is type 1, Homocystinuria type 1. Then here vitamin B12 absorbed from intestine. Vitamin B12 absorbed from intestine, it is converted to methyl B12. It can be converted back to vitamin B12. Here N5, N10, methylene THF, tetrahydrofolate, methylene tetrahydrofolate. It can be converted to N5 methyl THF, N5 methyl THF by the enzyme N5N10 methylene THF reductase, N5N10 methylene THF reductase, and it forms N5 methyl THF. This N5 methyl THF by the enzyme N5 methyl THF homocysteine transmethylase, this N5 methyl THF is converted to tetrahydrofolate, that is THF. Then this THF here, vitamin B12, this transmethylase can be converted to THF. Then this vitamin B12 it can form methyl, by accepting methyl group it can form methyl B12. So here in Homocystinuria type 2, it is an autosomal recessive condition. Here the enzyme deficient is N5 methyl tetrahydrofolate cystine homocysteine transmethylase. This enzyme is deficient. So N5 methyl tetrahydrofolate cannot be converted to THF. It cannot form methyl B12, and here Homocystinuria occurs. Clinical features include mental retardation. So the enzyme deficient is N5 methyl THF homocysteine transmethylase. Here blood shows increased level of homocysteine, because homocysteine cannot be converted to cystathionine. So increased level of homocysteine and homocystine, and these are excreted in urine. Here also nitroprusside test is positive. That is type 2. Then in type 3, Homocystinuria type 3, it is also an autosomal recessive condition. Here the enzyme defect is N5N10 methylene THF reductase. So N5N10 methylene THF cannot be converted to N5 methyl THF. So further reactions cannot take place. So that is Homocystinuria type 3 due to the deficiency of the enzyme N5N10 methylene THF reductase. Here the clinical features include mental retardation, then blood shows increased homocysteine, then this homocysteine is excreted in urine, and here also nitroprusside test is positive. Then both type 2 and type 3 Homocystinuria show response to folic acid administration. So that is about Homocystinuria type 2 and type 3. Coming to type 4, this is due to defective intestinal absorption of vitamin B12. That is Homocystinuria type 4. So these are the inherited disorders of sulfur containing amino acid. This is today's topic. Thank you for watching.